Thank you everyone for joining today. We have some really exciting content today. Things are a little bit different today. We have a special guest here with us. Usually it's Justin, our VP of Sales, and myself. But today we have a special guest, David Valentine. I'll start and introduce myself real quick, and then I'll let him introduce himself. For those of you that are here and you are a regular, so this is not your first webinar, thank you for coming again. For those of you that are new, my name is Anthony Velasquez. I am the Chief Product Officer here at PharmaForce, overseeing the technology and product lines that we provide in the 340B space. I've been in the 340B space for over a decade, spent the first half of my career working for covered entities, grantees, hospitals, et cetera. And then the last, 6 years, I've been on the TPA side. So I have that perspective of both sides, having been a provider and now being a TPA technology provider. So I have that unique perspective, and hopefully that's helpful in these educational webinars. Dave, why don't you go ahead and let everyone know who you are, since this is your first time joining us on this webinar.
Thanks, Anthony. Thanks for having me here on your webinar this week. And hello, everybody. Thanks for attending. My name is David Valentine. I've been with PharmaForce for just over 2 years now. I'm approaching the next couple years, it's hard to say this, but three decades in the pharmacy industry. So majority of my career has been set in the managed care space. So working at PBMs, health plans within the pharmacy department, managing pharmacy benefits, and different areas of pharmacy, both in hospital and ambulatory settings. For a brief stint, for a couple of years, I was a 340B manager at probably one of the country's largest health institutions and contract pharmacies network that we had there. So a lot of my time and my whole adult career has been spent in pharmacy and pharmacy benefits and ensuring people get the drugs that they need.
Cool. Well, hey, thank you for that introduction. I know that you're a wealth of knowledge in the PBM space. My thing is 340B. I don't really know the PBM stuff too much in depth like you, but I'll be asking you some questions today so that we can all learn together. All right, so let me say a few things before we get started. So this is going to go the same way it has been in the past few months, but a little bit differently. We're not going to use slides. It's going to be more of an interview/conversation with Dave to talk about the launch of our new PBM. What does that mean? What does 340B and PBM services for self-funded employers? How do those things work together? How do those two worlds collide? And so we're going to try to share that today. In the past, some of our topics have been on ways to optimize your 340B program, right? We did a session back, I want to say it was in October, of the 5 ways that you can increase your capture rate. We've done sessions on how to maximize manufacturer exclusions. So this is along that same spirit of what I will call an advanced strategy in 340B of seeing how you can utilize your PBM self-funded employee program and marry that with your 340B program in a way that optimizes your 340B capture rates and opportunity. Now, why is that important, right? If you're sitting on this webinar and you're asking, hey, why is that important? Well, I'll tell you why. I just read a statistic that close to 200 rural health hospitals have closed since 2005. So hopefully that proves the point that healthcare providers, especially rural healthcare providers and others, are facing a time of reduced payments, labor shortages, increased cost across the board, 340B manufacturer restrictions that are really crippling some hospitals and some grantees across the United States. So it's an interesting time where I think more than ever, entities ought to be strategic and thinking through how to optimize their 340B program and how to find and educate themselves on these strategies that other health systems are doing and taking advantage of, and they're able to see a benefit to that. Dave, anything else that you will add before I move on?
No, I think it's a great way to, I think, help offset your employee health plans, drug costs,
Yeah,
by mirroring that 340B component, because most of our employees, my experience has been working in health systems, is they're using the services that our health system provides. And getting those prescriptions qualified as 340B eligible is not really a stretch.
right.
So I think it's a great way for those of us that are tasked with managing our drug spends, and a way to leverage that 340B program to help kind of curve the trend in the right direction, as drug costs continue to go higher and higher, especially in the specialty space.
Yeah. All right, so let me say one other housekeeping item. So let me say that you all know my standard disclosure. Nothing in this presentation should be constituted as legal advice. This is for educational purposes only. I wouldn't consider myself an expert. I'm a professional in the 340B space. I would consider Dave an expert. Dave, I don't think you can say anything of a 3-decade long career in the PBM space, but so this is just educational content that hopefully will help you learn and take it back to your 340B covered entity. All right, so here's what we're going to do. We're not going to have a ton of slides like I've had in the past, where I have a slide for every topic, because I want this to be very conversational. And these are some of the things that we're going to touch on. Okay. So before we move forward, let me lay out the case. Okay. Let me lay out the case in case you're still sort of wondering, hey, what does a PBM and a 340B program have to do with each other? Okay. So more and more in the United States, we have healthcare institutions that are moving to a self-funded benefit plan in order to reduce cost, right? So you are a large hospital, or you could be a rural hospital, and you are a health center, and you're wanting to provide, and you're most likely, I would say, 99% of the time, those institutions are providing benefits to their employees. And they are providing pharmacy benefits. And in most cases, we're seeing a trend, an increase of the number of self-funded employers. And we'll talk about that in a little bit, what the difference is. But we're seeing an increase of that, which puts more of a burden on the covered entity and the hospital to manage that drug spend, to find ways to control that drug spend, ultimately in the benefit of the organization, but also keeping in mind that they're wanting to provide great benefits to us, the employees that are working at those organizations. So that's one. Number two, as Dave was sharing, some of the best healthcare institutions in the United States are also 340B eligible covered entities. All right. So you have situations where you might have I worked at a hospital in Center City, Philadelphia. It is an institution where patients came from all over the world to receive services. Myself and my family got services there. So are all employees considered 340B eligible? No. They're considered eligible if they meet the defined HRSA patient definition. And in a lot of cases, that is the case, where the employees are utilizing the healthcare services that that institution is providing. Okay, so those are sort of like the high level facts. Now, I have managed two hospital 340B programs in the past, where never was there a conversation or a strategy session or a meeting with anyone from benefits to try to figure out how could we use the 340B program to optimize benefits provided through the self-funded plan. That was never a thing. There was never conversations. There were never discussions. The benefits folks were never part of our 340B compliance meeting. They were two different worlds in two separate islands. Okay, so one of the things that we're hoping to communicate today at the end of this webinar is give you some strategies, and I'll share at the end, I'll sort of summarize everything, but give you some strategies of ways that you can use your PBM adjudication data, with a caveat of protecting the employees, right? You want to protect the employees' information and PHI, but you can use that data to find different metrics to help you optimize your 340B program. And I will share that at the end, so you don't want to leave. Okay. Now, Dave, let's turn it back to you. We launched our own PBM. You're leading that entire initiative of that PBM. We did that with 340B in mind. But educate us. Why did we launch a PBM? There's already hundreds of PBM. There's some really large PBMs. Why did we launch a PBM, and why is our PBM different than those in the market?
Okay, great. One universal truth is that I found in my years is nobody likes their PBM, right? I mean, they're a necessity in our distribution process, right? I mean, in order to have a pharmacy benefit, you have to have a PBM to do that claims adjudication and all the things that PBMs do, which provide a valuable service. But nobody likes the PBMs, and sometimes it's the PBM's own fault and the way they've done business in the past that kind of created that feeling towards them. We at PharmaForce entered the PBM market to be an industry disruptor, to be an alternative to those big three PBMs or even some of the bigger mid-sized PBMs that are in the market that pretty much all kind of have the same plan of business and how they operate. We want to change that. We ultimately want to change healthcare from a pharmacy benefit perspective by helping to offer that alternative that focuses on achieving the lowest cost, but also providing the best pharmaceutical care to the patient. We want to give the levers that traditional PBMs use, and when I say levers, I mean decision levers, that those PBM use to generate their own revenue. We want to give those to our customers to help them manage their pharmacy benefits and drive down the cost of those benefits that they're providing. Some of the big traditional PBM challenges are lack of transparency. There's no secret there. Like, a lot of PBMs are very murky in their reporting, and it's by design. There's lots of conflicts of interest in the current PBM traditional model, where the PBM owns the pharmacy, they own the mail order, they own the specialty. Sometimes there's a health plan that even owns the PBM. So there are some conflicts of interest there. And also wasteful spending. They're making a lot of times decisions on what drugs to cover based on what's good for PBM revenue, but not what's good for the actual patient or what's good for the employer. So they're conflicted just in their business model. Now, we're trying to change that by being flexible, offering not just off-the-shelf solutions, but being customizable to each client specific needs. We're trying to bring simplicity to a very complex part of our benefit, making plan sponsors feel that they can actively manage their pharmacy benefit management. And that was one of the things PBMs do, is they make you feel that you can't do this work, you can't manage it, you just kind of delegate everything. And once you do that delegation, the PBM then controls everything, including all the decision factors. And then lastly is formulary and network configuration, choosing what drugs, which pharmacies. When the PBM's doing those decisions, their best interests are the revenue they're generating, not necessarily in the level of care that employees are going to be receiving as patients, or in the financial decisions on what that's going to cost the plan sponsors or the employers at the end of the day. Because at the end of the day, it's not the PBMs that are paying the bill, it is the actual employers themselves.
Right. And then, yeah, so like some of the scenarios, like I know I experienced this myself, where I worked at a hospital and we had to use the mail order pharmacy. I'm not going to mention the name of the PBM, but we had to use the mail order pharmacy. And that's where you had sort of like the zero copay situation. Otherwise, I would have had a significant copay to go somewhere else. And it was like to get an albuterol inhaler or something like that. So what you're saying is, like, um, some of those PBMs don't allow you to configure any of that. You're basically just getting the PBM, and the PBM is just telling you, this is what your employees can get. These are the pharmacies you have to go. This is the formulary that you're using. And that's basically just, you're just signing on the dotted line and say, okay, that's what we'll do. But you're not really considering or you don't have the flexibility to switch those things out, right? To make this.
You may get an option, Anthony. You can have option A or you have option B, but there is no customization of A or B. It's you
Yeah.
can have that choice. And a lot of our health systems and hospitals, who's better to take care of their patients and make those clinical decisions than those those clinicians that are rendering the care to begin with?
Yeah.
So we're trying to take that decision point and put it back kind of in the hands of the employer through their clinicians versus being it managed by some PBM that kind of has their own revenue as the heart of everything they do.
Okay, so that makes sense. And I guess like, so what do you know any statistics on what like how many well, first of all, explain to everyone what is self-funded? What does that mean? What's the difference between self-funded and non-self-funded in the context of this discussion? Number one. Number two, um, yeah, like do you know any statistics behind how many employers are going towards a self-funded model?
Yeah, I guess to answer the first question, we have two models in this country. We have an insured, where you have an employer who enters a risk pool through the insurance company, right? The
Mhm.
insurance company basically, through some underwriting, says this is what we think your benefits are going to cost, and then the employee and the employer pay a premium, and that kind of goes into the risk pool, and the insurance company pays claims based on that. Self-funded is when the employer says, hey, I'm going to take on all the risk, that I'm essentially going to pay the bills. There is no risk pool. There is essentially, I am paying the bills for my employees. Employees still contribute their monthly premiums and such, but it's the employer that's kind of at risk. If somebody has some catastrophic health event, they're paying the bills. There's like no shared pool with other employers through the
Right.
insurance company. Now, the trend is it used to be a very heavily dominated insured market where employers would go to insurance company like Aetna, Humana, the Blues of the United States, all those kind of insured health plan, medical plus pharmacy products, and get the coverage for their employee benefits through them. But over time, we're seeing that phase is kind of going more towards self-funded now because employers are looking like the insurance companies, the PBMs, all these things inflate the actual cost. And employers are paying more, getting less services, lower quality of care.
Right.
So they're looking at it that if we accept more of the risk and we're the ones ending up paying the bills, then we can have the opportunity to have more decisions in that. And that's kind of why we targeted self-funded, because as a self-funded, you have more flexibility in selecting who your vendors are, like being able to select your own PBM or select your third-party administrator. If you're in an insured model, you typically have to go along with whoever the insurance company is partnered with. Sometimes it's a sister company or another vendor that they've partnered with to do the pharmacy benefit management work. That as an insured type of customer, you don't have options. You get whoever the insurance company works with. But if you're self-insured or self-funded, then you can do the vendor selection yourself. You have more control and more say in who your vendors you partner with.
Yeah. And the other big thing, like PBMs, obviously, I think everyone on this call that is in the healthcare space, in pharmacy, in 340B, knows the big fight with PBMs as it relates to, even in the context of 340B, discriminatory reimbursement rates. So that's a big thing that providers have been facing for. I mean, I remember this in 2013 working at a health center, and we were receiving discriminatory contracts where the PBMs were saying, your 340B, you have to identify the claim. We're going to pay you less for that claim. That's still a thing now, and it's a reason why many states and even in actually the new draft bill that's being proposed in Congress, the Sustain 340B Act, which that will probably be our next webinar topic, by the way, for everyone listening, will be to break down that Sustain 340B Act. But um, even in that bill, there's language against discriminatory rates, right? So you kind of see how, when you don't have any control, all of the things that sort of, the PBMs would just do. And unfortunately, PBMs don't have a good reputation. at all in the
None.
market, and with employees, with employers, with the public,
Providers.
with providers, with Congress. They just don't have a good reputation. So with that being said, like how my question I have here on number four is, aren't all PBMs the same, right? And obviously the answer is no, they're not, right? But I want you to highlight, I know we've used some terminology as like we're the anti-PBM. Like what does that really mean to you? And I don't think you have to go through and hash like all the benefits, because I think you made a very clear statement on why we launched our PBM, but what helps you, feel good about being associated with a PBM, which I know you come from other employers where you didn't feel as good
Yeah.
representing, those employers.
Yeah, I think the easiest way for this group is to maybe give a list of what are some of the things that you'd want to look for in a PBM, right? Like what are the good qualities you'd want to, kind of a little bit of a checklist. So the first thing is you want to pass through PBM, meaning there's um no smoke and mirrors about what the employer's paying versus what the provider's getting. There's this term called spread pricing, where a PBM will pay a pharmacy X for a prescription, but then invoice the client for another amount, and then they retain the difference between those as profit. So you want pass through, meaning everything is kind of above the table. The employers can see what the providers are getting billed and paid, and everything's clear to them as far as where their dollars are going each month to pay for the pharmacy benefit. Another key thing I'd look for is a PBM who has some drug spend management tools and programs, because that's one thing that we need to try to control. As we know, drug spend, all my years, it goes up and up and up. I remember when I started, we didn't think that drugs would be more than $99,999. And now I'm sitting on NCPDP calls where we're talking about extending it to $1 million to adjudicate a claim. So drug costs continue to go up. So you need to partner with somebody that has strategies, programs, and solutions to help you manage that drug spend trend, which includes like being able to customize your formulary, especially if you're a hospital. You know, your clinicians are working in the hospital, you have a set formulary. You want to try to align those, especially when we layer the 340B program. If you can't customize your formulary, it's going to be hard to leverage 340B. So being to have a partner that allows you to do your own formulary customization. Having somebody that has a flexible pharmacy benefit design. A lot of PBMs come to you and say, here are the three options you can choose from, when you should have somebody that's willing to partner with you to meet each individual needs you have, but also will even partner with you in modeling pharmacy benefits, that if you want to make these changes next year, let's say you want to change your copays, what does that look like to the health plan? What does that look like to the employees? What's going to be the disruption to the members for having increased costs? So
Right.
working with somebody that's going to be able to model those out for you.
Because
Um,
you're saying, Dave, in some cases you can't even do that. Like you can't even change your copays that you want to.
no, because their technology may be so old and antiquated that they are set in, and that's the only options they have. And anything else may be a code change that they're not willing to spend the resources and dollars associated with changing their system.
Yeah.
When we built our system, it was all about being customizable through options and not requiring code changes. So some of the older PBMs that are on technology from the 80s, early 90s, it may be a big stretch for them if you want to get creative with some of the latest, pharmacy benefit management tools we have that pertain to patient cost shares and different specialty tiers and things like that to help manage those high cost drugs.
Yeah.
Um,
What
Another
I
thing, oh, go
Yeah.
ahead, man.
No, no, go ahead, go ahead. Finish your thought.
I was just gonna say another thing is partnering with pharmacy network partners that are like-minded with cost control. You know, a lot of times the PBMs have basically pushed the pharmacies away and they view them as just a necessary evil to dispense the drugs.
Yep.
You know, we're here at PharmaForce, we try to treat our pharmacy network um, providers as partners. And we try to partner with people that have that same thought process of trying to, reduce the overall cost. And in the pharmacies, and when we're going through the contracts with them, we're very, very excited
Yeah.
that to partner with that kind of concept and not just looking like, oh, here's your contract, take it or leave it type of situation.
Yeah. Okay.
Real quick, just to wrap up, because I know we're limited on time, but partnering with somebody that looks at technology and digital health solutions, we all know the more technology we have, that usually lowers the cost, if it's just even admin costs. Having robust reporting, that's important to make these financial decisions, having the data at your fingertips to have the data help you drive those decisions. Having a partner who's flexible logistically. So if you think you can do your prior authorizations in-house, have partner with a PBM that allows you to take on some of those traditional PBM functions to help lower the cost of the administrative cost of that. And if above anything, I would say pick somebody that has the most transparency. The most transparency will give you the most insight, will give you the best decisions you can make, and you're probably going to have a higher level of satisfaction with that PBM than if you were to choose a PBM that may be a more established, bigger PBM that kind of falls into that traditional PBM business model that
Yeah.
we see, and that's given us the bad name in the industry.
Yeah. All right, so Dave, I appreciate all that information. Now, so here's how to let's put the bow on top of the present, right? What does that have to do with 340B? Here are three things, three strategies, three data points that when you have access to the PBM adjudication data, to your employee benefit data, how does that translate from a 340B perspective? Number one, you can look at your pharmacy level usage. Where are your employees going? Maybe you do have a self-funded plan that it's already a lot more open than it would be, with a more traditional PBM. Maybe you have that. Well, when you are able to then look at that data and see that all the pharmacies where your employees are going, especially the ones where there's the most spend, that you make sure that that pharmacy is a pharmacy in your 340B contract pharmacy network. That alone can uncover a significant amount of 340B additional savings for your healthcare institution, right? Know where your employees are going, and if they are going to a pharmacy where they're getting specialty medications and things like that, that you make sure that pharmacy is a contracted pharmacy on your 340B program. So as the pharmacy benefits team, and your 340B team work together, this is a strategy that can be implemented to ensure that those two things are aligned. Number two, seeing which providers are writing the most expensive drugs. So I know one of the things that we're doing as we're providing sort of a dashboard that shows the two together is showing the top 10, top 20 providers that are prescribing products to your employees by drug spend. So if that is a neurology office, a GI office, a whatever it is, that you're able to know whether that provider works at a location that's 340B eligible or not. And that could lead to strategies that could potentially increase 340B capture rates. So pharmacies, providers, number three are the drugs. This is my favorite and the one I'm passionate about because I have been personally impacted by situations where the PBM said, we're not going to cover the branded albuterol. That's the one that I like. That's the one that helps me. That's not going to be covered anymore. We're going to give you this other alternative, and it's not as good and it sucks, but it's cheaper to the PBM, so that's what's covered. Well, in this model, the entity has flexibility. The entity has the ability to then go and provide the better product if by considering the 340B pricing as part of their formulary setup because of all that flexibility. So those are some of the things where the two kind of can work hand in hand, and that's what we're seeing our customers looking at those strategies. How can they look at their self-funded plan and their 340B plan and see that working together? Dave, I want to give you the last about 30 seconds to give us a quick success story in the making that we're working with right now so that everyone can see this in action. And then if you stay afterwards, we will have a short Q&A. You can unmute yourself. Or I see there's 3 questions in our Q&A box, but if you do stay afterwards, we'll have a Q&A. Dave, you got 30 seconds to close us up here.
So we have a customer that was a 340B customer of PharmaForce that transitioned their employee pharmacy benefit program to the PharmaForce PBM beginning in January. And we're working with them to help leverage what we're talking about here. We've been able to work with them to customize some strategy, which includes customizing their formulary to align with 340B costs and having the right drug selection there. Managing their pharmacy network in such a way that we're kind of utilizing the health systems, hospitals that they own, and through benefit management, basically kind of steering the members back to the hospital-owned pharmacies for maintenance drugs and things like that. Using a manufacturer copay program optimizer. So not only using 340B, but also utilizing those coupons to help offset some of the planned drug spend to them. Helping them with their specialty drug management. Everybody knows the elephant in the room is specialty drugs. So working with them on specialty, using a combination of strategies to help reduce those costs. And also managing the prior authorizations. Before, they used to have their previous PBM, they felt like everything was approved. There was no reason they're getting, $80 a PA charge. Now they've taken that PA on work themselves and they feel like it's under more control, it's more cost effective, and there's better decisions being made. So we're hoping in the next 6 months to have some really good metrics to share with our health system hospital customers and kind of put the punctuation point on, what we're talking about here, that this is a viable solution to help manage your pharmacy drug spend for your employees.
Awesome, Dave. Thank you so much for that, and thank you for joining us today. Um, let's take a couple of questions. So again, I want to thank you all for your time. We try to keep this to 30 minutes and just jam pack them with good content and education. So hopefully you're leaving here today having learned something different, something new, maybe something you could take back to your entity and your team. Feel free to reach out to us if there's anything that we can answer. If you email us at info@thepharmaforce.com, if you have a question for Dave, you have a question for me, those emails will come to us and we'll be able to respond.